anywhere else. I'm part of an orthopedic group. It's called the Advanced Orthopedic and Spine Care. I have 2 offices. One is in Tinley Park, and the other is in Oak Lawn. And I am part of 4 hospitals. So I'm part of Silver Cross, Masonic in the city, and South Suburban in Hazel Crest, and also Christ, which is in Oak Lawn. So today's topic is wound care and interventions, and we will get started. So just disclosures, I do not have any financial disclosures, no affiliations with any companies. And for this topic, I hope you learn a lot. But these are the 4 points that you will be taking away. The first one is you'll be able to diagnose a critical limb ischemic issue in a timely manner. Time is important and critical with critical limb ischemia, and you will see why. You will be able to provide the proper workup for better patient care, improve your patient care skills. And something really important that we don't really talk about is patient bias that we have at our hospitals. So we're going to be able to reflect on the patient populations that we serve and consider how implicit bias can impact appropriate care of these patients and how we can supplement to better care for our patient populations and where we practice. So, introduction. There are many definitions of critical limb ischemia that we will talk about, but just to begin, critical limb ischemia, abbreviated CLI in my presentation, is a clinical syndrome defined by ischemic pain at rest and ischemic tissue loss, and it does present itself as ulcers and gangrene. It's related to peripheral arterial disease of the lower extremities. It does differ from acute limb ischemia. My topic is mostly on critical limb ischemia, but I will talk about acute limb ischemia just to have full knowledge of the topic, since we will be seeing those patients as well in our hospital and clinic environment. So acute limb ischemia is a sudden loss of limb perfusion, usually caused by an embolus or thrombus, and it presents itself in less than 2 weeks of the acute event. In the case of critical limb ischemia, it does take several months, to weeks to months, to present in our hospital setting or clinic setting, and the damage results from ischemic pain and ischemic damage, and it is really on the end spectrum of our chronic limb ischemia. So critical limb ischemia is important to fully understand and diagnose and treat in a timely manner because of the much higher risk of limb loss and cardiovascular events than asymptomatic peripheral arterial disease and intermittent claudication. And intermittent claudication, just to be thorough, and those who don't know what that is, intermittent claudication is pain during exercise, but that does dissipate at rest. And this poor prognosis of chronic limb disease and critical limb ischemia urges a rapid assessment and fundamental involvement of wound care and the earlier use of revascularization. So furthermore, a multidisciplinary teamwork approach involving specialists in vascular surgery, podiatry, wound care, infectious disease, internal medicine, as well as other specialties is essential to maximize the chances of limb salvage and patient outcomes. And just so I know who I'm speaking to, just a raise of hands, who's a nurse? Or a nurse practitioner? And then internal medicine, great. Podiatry, vascular surgery or interventional cardiology, fantastic, infectious disease, and then anyone that I'm missing, just shout out.
We're just RVTs, I don't know if we go into vascular surgery.
You are fantastic, we love you, thank you for being here. Just a quick reflection for classification systems. These are the 2 main systems that I use, and this is a way to interact with all of our teams. And if someone comes up to me and says, I have a Rutherford stage 3, what does that mean? And what does that mean in terms of critical limb ischemia or intermittent claudication, and even critical limb ischemia? So just to point out, stage 4, 5, and 6, which link to rest pain, ischemic ulceration, limited to just the digits. And we are focusing on the lower extremity here. Severe ischemic pain and ulceration are all linked to stage 4, 5, and 6, and this does correspond to our Fontaine classification of stages 3 and 4. So just some quick definitions for critical limb ischemia. Critical limb ischemia aims to identify patients who are at risk of major limb loss without the intervention of any vascular revascularization or any wound healing principles or debridements that are performed. So when your patient comes in and is fresh or virgin to you and hasn't had any treatment done, that is how you start to define what classification of critical limb ischemia they are put in. Rest pain and tissue loss, such as ulcers and gangrene, support ischemia defined by hemodynamic criteria of low ankle and toe pressures and low transcutaneous oxygen pressures, or values. So ankle pressure criteria range anywhere from less than 40 to 70 millimeters mercury, which defines critical limb ischemia. And just for reference, the normal range is anything greater than 80. And toe pressures of less than 30 to about 50 millimeters mercury define critical limb ischemia, but the normal range can be anywhere greater than 40 again. So there's a discrepancy in our definitions. And transcutaneous oxygen pressure of less than 20 to about 40 defines critical limb ischemia, but realistically, our cutoff is, 30? So there is no true definition of what critical limb ischemia is, therefore there's a lot of overlap, and you actually have to look at the whole patient rather than what your value on a test is when defining critical limb ischemia and finding the correct treatment for these patients. So higher cut points are usually used for tissue loss and based on the assumption that greater perfusion is required for wound healing. But like I mentioned before, expert consensus differs between guidelines. And other definitions of critical limb ischemia, it can incorporate wound infections and osteomyelitis in addition to the ischemia that is presenting. So this is just a great example of our overlap that we have. These are two graphs. One on the top, you can see that they're a little bit different. I'm sorry if I'm in your way. But the first one is the transcutaneous oxygen pressures of patients who had a revascularization or amputation versus no surgery. So the black rectangle is the transcutaneous oxygen pressure of less than 35. So that is ischemic issue. So patients who needed a revascularization were about like 75% of those patients, a little over that. And patients who had total of the transcutaneous oxygen pressure of greater than or equal to 35, about only 40% of those needed a revascularization. And those that did not need surgery, you can see, are just corresponding to the next grid. But when you compare that to the toe pressures, on the bottom end of our grid, you can see that the toe pressure of less than 38 millimeters mercury was all the way up to a bit over 80% needed revascularization. And then those with toe pressures of greater than or equal to 38, about 20% needed. And those who didn't have surgery with toe pressures of less than 38 millimeters mercury were at 20%. So really, we don't really have specific criteria of toe pressure or transcutaneous oxygen pressure in defining critical limb ischemia. And what's important to note is that in our younger patients, I don't know if you can see it well, I'm sorry, it's in black, but their distal vasculature is completely outdue, so you can't even assume what the values are in our younger patients. So rest pain and wounds suffice as a definition and criteria for critical limb ischemia in our intervention in this patient care population. So just some background, patient outcomes in critical limb ischemia are largely determined by morbidity and mortality caused by cardiovascular events and functional impairments caused by limb loss. Although overall, the whole spectrum of peripheral arterial disease and cardiovascular events, such as heart attack and stroke, account for 30 to 50% of patients over a 5-year period. Those with critical limb ischemia face the same 30 to 50% risk over a 1-year period. So this is even worse than some cancers and heart failure. So although the major risk of amputation, and a major amputation is defined as anything at or above the ankle level, is less than 5% following 5 years in patients with claudication, it's at least 30 to 50% in the first year of patients with critical limb ischemia who do not have a revascularization procedure performed. So how does critical limb ischemia present? What are we supposed to look out for? So chronic limb ischemia is manifested by pain at rest. It can present as gangrene and non-healing wounds, like a chronic wound that hasn't improved no matter what treatment has been performed to it. Ischemic rest pain, and this is typically described as burning pain. It's usually in the arch of the foot or to the distal digits. Any presence of that occurs while the patient is recumbent, which means when they're laying down, but this pain usually dissipates when the patient's feet are lowered and placed in a dependent position. So that is a criteria that I'll use with my patients when I diagnose with critical limb ischemia. And the clinical presentation of critical limb ischemia depends on the degree of ischemia, the presence of any infection, and coexisting neuropathy. So these all can mask your critical ischemia symptoms and actually the intensity of it. So when patients have pain at rest, they don't really want to walk. So when they don't want to walk, they're at risk of what? A blood clot. So that complicates them. So they're already put at a trajectory of needed intervention and an outcome of pretty much failure. And then infection can increase pain even without severe ischemia. So when you have an infection, you can't even gauge what your level of ischemia is. A neuropathy can contribute to tissue loss and mask pain from an ulcer. So you can have a patient who is a diabetic with neuropathy with the worst critical limb ischemia possible, but they may not have any pain. And current guidelines recommend measuring ankle pressures and ankle brachial index, although medial calcinosis can yield artificially high values in cases where toe pressures can indicate arterial obstruction. So the normal value for an ankle brachial index is around 1 to like 1.3. But literature says that 1.3 to 1.4 and on is not okay. So that means that there is calcification of the vessels, and you think that the arteries are patent, but they're really not. And then transcutaneous or skin perfusion pressures may indicate the probability of wound healing. So those tests are still very, very important to get.